And Dr. Lamas has already presented the background of the study, so I will not repeat that material. You've also seen this slide before. In essence, the 2x2 factorial design. We're going to be talking about the comparison of chelation therapy with placebo. Chelation placebo. Quality of life was one of the major pre-specified secondary endpoints of the trial. And you've seen this slide before as well, so I will pass directly into the next part of my presentation. The primary objective of the quality of life portion of TACT was to determine whether chelation therapy significantly improved physical functioning and psychological well-being, the two major components of health-related quality of life, in stable coronary disease patients with a history of myocardial infarction. Some of the relevant methods of our study, we randomly selected about half of the total TACT enrollment. 911 patients was the final sample, representing 53% of the population. As I said, randomly selected. Quality of life was assessed through structured interviews at baseline, 6 months, 12 months, and 24 months. All the baseline questionnaires were collected at the time of enrollment by the site coordinators who were trained to do these structured interviews by the DCRI outcomes group. The follow-up interviews were collected centrally at Duke by the DCRI outcomes group using telephone interviewing techniques. We were able to collect 97% of the expected quality of life context that we set out to collect. We did not have a lot of guidance from prior literature based on exactly what to expect in terms of potential quality of life effects of chelation therapy. So when we designed the study, originally we selected two co-primary or co-principal quality of life outcome measures as what we thought would be the most likely to reflect an effect were one to be detected. The first of these was the Duke Activity Status Index, or DAISY, which reflects cardiac-related functional status and specifically assesses the ability of patients to do physical activities without difficulty or assistance in 12 separate domains. The second of these outcome measures was the Mental Health Inventory 5, which is one of the scales from the SF-36 that I think many of you are familiar with. This specific scale assesses psychological well-being in both its positive and negative dimensions, including both assessment for depression and anxiety. Other measures that we collected included 3 scales from the Seattle Angina Questionnaire, the entire SF-36, and the Euroqual, or EQ-5D. All comparisons were by intention to treat. Follow-up comparison p-values that I'll be showing you in a moment are adjusted p-values. They're adjusted for the cross-randomization to the vitamin group and for the baseline quality of life scores. No adjustment was made in significance levels for multiple comparisons. Not on the slide, but on the final slides is also a point that we had over 90% power to detect essentially one quarter standard deviation difference in the primary endpoints. DAISY, for DAISY, that would be 4 DAISY points with the sample that was enrolled. Baseline characteristics, you've seen those for the overall trial. This is for the quality of life subgroup, and as you can see, hopefully the groups were well balanced by randomization. The characteristics of the population have already been reviewed with you. I would only highlight, in addition to what you've heard, that 80% of the patients did not have anginal symptoms at baseline. So the proportion of patients reporting any anginal symptoms at all was a small minority of the total population. This is one of our 2 co-principal quality of life outcome measures. Again, just to orient you to the slide, the chelation arm is shown in yellow. The placebo patients are shown in green. On the y-axis is the Duke Activity Status Index, which ranges from 0, which is the worst possible score, to 58, which is the best possible score. as I said before, for at least a rough benchmark, an improvement of 4 DAISY points, which is about 1/4 of a standard deviation, is generally considered to be clinically significant. So what's shown on these slides, which is not the final version of the slide that I will be using this afternoon, is that the improvement in DAISY was about the chelation group had a 2-point difference over the placebo group at 6 months, a 3-point difference at 12 months, and a 2-point difference at 24 months. None of these differences were statistically significant. This is the other co-principal quality of life outcome measure, the Mental Health Inventory 5, or the MHI-5. Again, the setup is the same. Remember that the p-values are adjusted, and the differences between the groups at 6 months in the unadjusted version of this, which is what I'll be showing this afternoon, it was no difference at 6 months, a 1-point difference at 12 months, and a 2-point difference at 24 months. And this is scaled to a mean of 50 with a standard deviation of 10, meaning the average value for the general U.S. population on this scale, age adjusted to this population, is 50 plus or minus 10. The third result that I'll show you this morning is the Seattle Angina Questionnaire Anginal Frequency Scale. And this is scaled from 0 to 100, with 100 being the best possible score, essentially no angina, 0 being the worst score. And you can see that at baseline, the populations, the two groups are very high to begin with, corresponding to what I showed you on the baseline characteristics slide, with only 20% of patients reporting any angina at the time of enrollment. In follow-up, there are small differences between 1 and 2 points on this 0 to 100 scale. Again, none of these differences are statistically significant. I'm going to skip this one and just mention that there were no pre-specified subgroup comparisons that showed an effect of treatment on quality of life. A couple of caveats to point out. First, as I've said several times, the trial population was largely asymptomatic from a cardiovascular point of view at baseline, and that created a ceiling effect for some of the measures that we used. In other words, they were already so high that it was difficult to show any further improvement on the basis of any therapeutic intervention. This was particularly true for the Seattle Angina Questionnaire items that we used. The second caveat is that quality of life assessment follow-up in this study was limited to 2 years. That was the length of follow-up that was planned at the time when the study was originally designed. As you've heard, the plans for this study were adapted over time, but we did not have the resources to continue to follow quality of life beyond that. And the clinical results that you've seen showed that there was significant continued divergence favoring chelation out to 5 years, which we were not able to track in this portion of the study. In summary, I would suggest that in a population of stable, predominantly asymptomatic coronary disease patients with a history of prior MI, the use of EDTA chelation therapy in this sub-study did not produce a consistent, sustained improvement in any domain of health-related quality of life. Thank you.
Thank you, Dr. Mark, for bringing that patient-centered form of investigation to our discussion. The next will be a presentation by Dr. Elizabeth Magnuson from Kansas City to talk about the cost-effectiveness analysis.